Good day. Welcome to your first lecture. And this is all about cardiac diagnosis, an integral part of a patient's complete problem list. This is a diagnostic process. The patient initially experiences a health problem that prompts the patient to engage with a healthcare facility, for example, the hospital or your clinic. You, as a physician, will collect clinical history and physical examination, integrating this gathered information with diagnostic exams to formulate a working diagnosis and determining the need for referral. The diagnosis is then communicated to the patient. A treatment plan is formulated, then executed, then the patient is followed up. The process of formulating the diagnosis takes a central role that links patient symptom to management. In 1932, Paul Dudley White, founder of the American Heart Association, published The Heart. Together with Merrill Myers, advocated the use of threefold diagnosis that includes etiology, pathology, and functional condition. Cardiac diagnosis for him can lead to prevention of the disease. Heart physicians were stimulated to incorporate this important new concept in the New York Heart Association's book on nomenclature and criteria, and on its seventh edition included etiology, anatomy, physiology, cardiac status, and prognosis. Thus, combining cardiac diagnosis by the New York Heart Association and complete problem list by LL Weed improves learning, communication, patient care, and clinical research in patients with cardiovascular disease. So what are the components of a cardiac diagnosis? The cardiac diagnosis is composed of the underlying or the origin of the cardiac disease, the anatomical changes that resulted from the underlying disease, the compensatory, adaptive, or physiologic effect of the disease, and the changes of the patient's functional capacity in response to the disease. So etiology of the cardiac disease refers to the cause or origin of the disease. This can either be congenital or genetic, toxin-mediated, metabolic, hypertensive, valvular, inflammatory, atherosclerotic, or infectious. Practically, there are a lot of etiology in cardiovascular disease. In determining the etiology of the cardiac disease, one should have a complete history and physical examination that is confirmed by sound diagnostic procedures. The physician should look at non-modifiable risk factors such as age, sex, race, as well as modifiable risk factors such as smoking, alcohol intake, and comorbid condition. For example, congenital heart diseases are usually seen in young patients that may also present with birth defects. Atherosclerotic disease, on the other hand, have risk factors like hypertension, diabetes, and the presence of anginal syndromes and a positive coronary angiogram. Now let's move on to the anatomic diagnosis. The anatomic diagnosis summarizes the structural changes of the heart secondary to the underlying disease, and they may be congenital or acquired lesion. This includes changes in cardiac size and shape such as hypertrophy and dilatation, valvular involvement, primarily stenotic lesions, and involvement of the pericardium in pericarditis and in pericardial effusion. Anatomic diagnosis should answer the following question: what chambers are involved? Is there hypertrophy, dilatation, or both? Is there valvular stenosis? Is the pericardium involved? Is there myocardial infarction and or coronaries affected? And it is always interpreted with other ancillary procedures such as echocardiogram, PET scan, cardiac CT, and MRI. Physiologic diagnosis refers to the adaptive and maladaptive mechanisms in the heart in response to the underlying diagnosis. This should answer the following question: is there arrhythmia? Is there evidence of congestive heart failure and myocardial ischemia? Is there syncope? Is there cardiac shock, cardiogenic shock? Is there any valvular regurgitation due to changes in the valvular anatomy? Then it is followed by the functional class. Functional class is fundamental to understanding the cardiovascular status of the patient and serves to answer how mild or severe our patient is. This is based on what the patient describes and can be subjective. Physicians should ask how strenuous is the physical activity required to produce a symptom. To simplify it, you can ask what routine household activity can patient do without symptoms and activities that can or may produce symptoms and compare it to baseline functional capacity. The NYHA has formulated a classification of patients' functional capacity based on the occurrence of symptoms in relation to activity. First, class 1 is there is no limitation of physical activity, and ordinary physical activity does not cause symptoms. Class 2, slight limitation of physical activity, comfortable at rest, and ordinary physical activity causes symptoms. Class T, there is already marked limitation of physical activity, comfortable at rest, but a less than ordinary activity causes symptoms. Lastly, class 4 has severe limitation and discomfort with any physical activity, and symptoms are present even at rest. We can also estimate functional capacity by determining the metabolic equivalent of an activity that a patient can do without symptom. A patient with good functional capacity have 4 to 5 METs, or he must be able to climb a flight of stairs or walk uphill, or even have short distance run. So if you are going to combine underlying cause of the disease, anatomic changes of the heart, physiologic changes or adaptation, as well as changes of the patient's functional capacity, you can come up with an objective classification. So the objective classification is deemed to objectively determine how severe the cardiovascular disease is and take note of the patient's clinical status in objective measures of cardiac function and structure. So you are going to incorporate physical examination, history, as well as other ancillary exams such as echo, coronary angiogram, magnetic resonance imaging, and nuclear cardiology. This shows the objective classification. Class A has no objective evidence of cardiovascular disease. Class B has objective evidence of minimal cardiovascular disease. Class 3 has objective evidence of moderately severe cardiovascular disease. And Class D has objective evidence of severe cardiovascular disease. So let us take a sample case. We have SB, 25-year-old female, a voice talent. 5 years prior to consult, patient noted dyspnea after running 3 blocks, and there is concomitant palpitation, and these symptoms were relieved by rest. 1 year prior to consult, patient would experience dyspnea after 1 flight of stairs, and there is increased episodes of palpitation. She was initially brought to a primary hospital, and she was noted to have a murmur. She was advised cardiac consult, but patient was not compliant. Until 2 weeks prior to consult, patient noted to have easy fatigability even while speaking, paroxysmal nocturnal dyspnea, orthopnea, bipedal edema, and abdominal enlargement. Past medical history showed no hypertension, diabetes, and active cancer. Family history showed that the family history was uncontributory because patient was adopted. Personal social history, she was non-smoker, no intake of alcohol and illicit drugs, and used to join marathons and a 21-kilometer finisher in 2015. Review of other systems was uncontributory. Focused physical examination at the emergency room showed a hyposthenic patient who was unable to lay down supine with a blood pressure of 130 over 80 millimeters mercury. Heart rate was 126, irregular, respiratory rate of 34 cycles per minute, and a temperature of 36.8 degrees Celsius. She has distended neck veins, a JVP of 8 centimeter water at 45 degrees inclination. She has dynamic precordium, an apex deep at 6 left intercostal space anterior axillary line. She has RV heave, PA lift, a fixed split S2 at the base, and a grade 4 over 6 systolic murmur at the fifth left intercostal space parasternal line with positive car values assigned. Physical examination of the lungs showed symmetrical chest expansion, no retraction. There were crackles on both lung fields from T7 down. She has a globular abdomen, non-tympanitic, no tenderness, direct tenderness noted. However, fluid wave was not assessed. She has grade 3 bipedal edema. All pulses were full and equal. Can we give a cardiac diagnosis based on the history and physical examination of the patient? Definitely we can. So we now look at the different components of cardiac diagnosis. First, underlying cause of the disease. So this patient has history and physical examination that is definitely of cardiac origin. She is young. She has prolonged progressive symptoms. She denies any traditional cardiovascular risk factors such as hypertension, diabetes, dyslipidemia, and physical inactivity. She has no constitutional signs and symptoms pointing to an infectious cause such as fever. So we might be dealing with a patient with congenital or valvular heart disease. Now let's now look at the anatomic changes of the heart. Patient has a fixed split S2 that may point to an atrial septal defect. She has a displaced apex beat that may point to a left ventricular hypertrophy or right ventricular hypertrophy. This patient has an RV HIV that may point to right ventricular hypertrophy. Physiologic changes or adaptations would include the following. This patient has an irregular tachycardia that may signify the presence of atrial fibrillation. Patient has a PA lift and a split S2, which may also point to pulmonary hypertension or a dilated pulmonary artery. Patient has a distended neck vein with 4 over 6 murmur at the left parasternal line and is positive for Carvalho's sign, which is typical of tricuspid regurgitation. And the patient has signs and symptoms of fatigability, paroxysmal nocturnal dyspnea, or topnia, cardiomegaly in physical examination, as well as basal crackles and bipedal edema, which points to heart failure. We now look at the changes of the patient's functional capacity. And if you would remember, the patient had symptoms even when she is speaking at rest. So we have a class 4 patient. So the working diagnosis for SB would be etiology, congenital heart disease, anatomic diagnosis, atrial septal defect, right ventricular hypertrophy, left ventricular hypertrophy, dilated pulmonary artery. Physiologic diagnosis includes atrial fibrillation with rapid ventricular response, tricuspid regurgitation, and she is in congestive heart failure, functional class 4. The following are the ancillary procedures done. ECG showed atrial fibrillation and rapid ventricular response. Chest X-ray showed cardiomegaly, there are multi-chamber enlargement, as well as presence of pulmonary edema. Ancillary procedures like 2D echo was also requested that showed an ASD secundum type. You can note the presence of filling defect of the interatrial septum, and there is communication between the left atrium and the right atrium during diastole. And the QPQS was 2:1. There is eccentric left ventricular hypertrophy with normal systolic function, right ventricular hypertrophy. The right atrium, left atrium, and the main pulmonary artery are all dilated with severe tricuspid regurgitation and mild mitral regurgitation. The pulmonary artery systolic pressure was estimated at 62, which is markedly elevated. So if we are going to combine history, physical examination, as well as the different ancillary procedures requested, the working diagnosis for SB would be etiologic diagnosis, congenital heart disease, anatomic diagnosis, atrial septal defect, secundum type, right ventricular hypertrophy, left ventricular hypertrophy, dilated pulmonary artery. Physiologic diagnosis would include atrial fibrillation with rapid ventricular response, a severe tricuspid regurgitation, mild mitral regurgitation in congestive heart failure, functional class 4, and combining all the ancillary procedures, we have a severe heart disease. The objective class is D. Now I give you back to the diagnostic process. History and PE takes central role in diagnosing our patients. Thus, if you are going to combine history, which is subjective data, and physical examination, which is objective data, together with different ancillary procedures, we can come up with a diagnosis. And if you are going to do your POMR and progress notes, you can always come up with a good treatment plan and be able to follow up your patient. Thank you very much, and that is for your cardiac diagnosis lecture.